Good afternoon. This is Kelly Sheets, and I will be hosting today's meeting. It's good to see you all. Just a couple of things. Just remember, if you are a member of the TAC, please be sure to turn your camera on so that we can be compliant with open meeting laws. Also, I would just like to take a minute to remind everyone, if you have a question or a comment during the meeting, if you could please just raise your hand. When we get too many people talking at one time, it makes it very difficult for the court reporter to hear what's going on. So that's all I have. I have 1:30, and it looks like you need one more. Oh, here comes Arthur. Arthur's joining now. So I believe you do have a quorum.
Perfect. Thank you, Kelly. I appreciate that. And I was looking to see if some of our members were on with their cameras yet. If people could turn those cameras on now, that would be fantastic. I think I saw Miranda, Patty, I see you, Arthur, and Brenda Menino. I hope I got your last name right. Welcome.
I'm gonna try joining on my phone because I'm having trouble with my laptop camera.
Okay, no problem. Kelly, have you seen Christy Harden by any chance in the waiting room? Or?
No, I haven't.
Okay, so Christy is another new member representing the First Fee Coalition, so hopefully she'll be able to join us. But we can get started now that we have a quorum. Welcome, everyone. Thank you for taking time to join us today. I'm Emily Beauregard. I'm the Director of Kentucky Voices for Health and the Chair of the Consumer TAC. And I am getting over some sort of daycare virus, so bear with my voice. Excuse me. But we'll go around and do introductions, and I want to give a warm welcome to Brenda Menino, who is representing AARP Kentucky. So really glad to have you joining us today. Why don't offer some support for members for SEO? Why don't we just, in order of who I'm seeing on my screen, if you could introduce yourselves, Arthur, Patty, Brenda, and Miranda.
Who are you?
Yeah.
You want to introduce yourself?
Yeah.
His name is Arthur Campbell Jr.
Yeah.
And he's with PA.
Yeah.
All right, thanks, Arthur.
Okay, my name is Patty Dempsey, representing the ARC of Kentucky.
Brenda, would you like to go ahead and introduce yourself? You're muted right now, Brenda. You know, if you're not able to get the audio to work and you want to pop it in the chat and just do your introduction there, we can do it that way. I do know that with the court reporter who's taking minutes, we may need to make sure that anything in the chat is also being added in. I know that that was a bit of an issue last time with some of the statements that we had there. And Miranda, I see you were able to get on your video. Can you go ahead and introduce yourself?
Yeah, hi. I'm gonna shoot. I've got two audios going somehow. Sorry.
Oh, I hear the feedback now. It's not too bad.
Can you hear me?
That's actually worse.
Sorry. I'm Miranda Brown with Kentucky Equal Justice Center. I'm a connector, and yeah, happy to be here. Hope that was audible.
Yes, it was. It was very clear. Thank you. All right, so we've established that we have a quorum. We do have minutes from the previous meeting that need to be approved. Great. Thank you, Brenda, for putting that in the chat. Really glad to have you. So have people had a chance to look at those? Any questions? And of course, these minutes are now in the form of a transcript, which I know is quite long. But let me know if there's anything that you want to address before we make a motion to approve. Okay, hearing nothing, I'll ask for a motion.
A motion to approve the minutes from December.
Thank you, Miranda.
Yeah.
Second from Arthur. Thank you. All in favor, say aye.
Aye.
Any opposed? All right, the motion carries. All right, so we'll move on to the next item on our agenda, which is actually pretty lengthy, our old business, some of the the issues that we address on a regular basis during this TAC meeting. I know that Deputy Commissioner Veronica Cecil will need to leave early, so I'd like to turn it over to you to address any of the items on the agenda that you want to get to before you have to leave.
Thank you, Emily. Hello, everyone. So you will see me with a new headset. We have just moved our offices from the 6th floor to the 2nd floor in the CHR building, and to respect other people's, we're a little closer together now and do not have walls. So we're it's unusual for me to have these on. So hopefully you can hear me okay. This is my first Zoom call with these on.
Crystal clear.
Yeah, thank you. I am going to share if Kelly, if you can make me a co-host. I'm going to share a couple slides on a PowerPoint. This may look familiar to some. We first launched this PowerPoint about a week ago for some advocacy organizations. This is going to be a PowerPoint that we're going to share with groups as they ask us to talk about the public health emergency and unwinding. And in particular, I think what most people are really interested in right now is the restart of annual renewals for our Medicaid members. We will be updating this information on a regular basis, and I'm happy to continue presenting it as it's updated, going forward. So I might take a little bit more time today for this, and then in the future, just, kind of giving you all a status update as to where we are. Let's see here.
Veronica, you should be co-host now.
Yep. And can you all see my screen? No. Hold on one second. I think I shared it and then I stopped sharing it. There we go. Let's see. Okay. Are we good? All right. So just as a reminder to everyone, we have been under a federal public health emergency since 2020, and now what you may have heard is that those are that's coming to an end in itself, and then there was a new federal law passed in December that separated the restart of annual renewals from the public health emergency. So that might be a little confusing for folks, but we will start renewals after March 31st is when the end of what's called the continuous coverage that we've been under. We've been required to cover people and not terminate them except for 3 reasons. One is that they requested that we discontinue their coverage, that they moved out of state and we were able to verify they are no longer a Kentucky resident, or if they passed away. So those were the only 3 reasons during the public health emergency that we discontinued somebody. So as also noted, the White House did announce and did provide communications to the states that the public health emergency will be ending May 11th. That will require some additional activities as we move forward. This is a high-level timeline for the renewals. So we did just file with CMS, and it's under review, a redistribution plan. What that means is that we want to distribute the caseload across the 12 months of unwinding. We do have 12 months to perform those renewals. So we want to be sensitive to our workforce. We want to be sensitive to our call center, not being overwhelmed. And then we also wanted to strategically move our population across the 12 months, based on the type of case it is, because we have other ways of supporting, somebody depending on what their situation is. So we have submitted that to CMS and it's under review. As I noted, March 31st, the continuous coverage condition ends. It's after that point that states could start discontinuing somebody who is no longer eligible. For Kentucky Medicaid, we will be starting the renewals in May. So anybody who has a end date of their coverage as May 31st, those will be the individuals that will first go through a renewal. I'm going to walk through what that looks like here shortly, but that gets initiated in April, and then they'll have, if we can't renew them automatically, they will have to take some kind of action before the end of May to make sure that their Medicaid coverage does not discontinue. We do have, looking back to April 8th, we do have to file what's called a baseline report with CMS. They've asked for some specific metrics for us to report on. The baseline is for up until we start unwinding. So each state's going to be a little different. And then we are required to file a monthly report every month with CMS that updates that information dependent upon what our renewals look like. And then, as I mentioned, that last May 2023 through April 2024 is the 12-month unwinding period. So this looks a little overwhelming, and we'll send these out so you all can really take a closer look at it. But what this is just trying to explain is, what does that process look like for, all the different pieces to unwinding? So in March, as you see, it shows that in March, what we'll do is send out a notice to anybody who has a May renewal. So they'll get a text or an email to say, hey, guess what? You've got a renewal coming up. So they will try to communicate. We'll try to communicate with that person and let them know that there is something happening, a change in what they're used to, and just to be on the lookout for that. So then come to April, April 1st, our system will try to verify everyone in May that has a May renewal date. And if our system is able to renew them, because we've got all the information we need and we're able to do that electronically with nothing else from them, they'll get sent a notice of eligibility. And so they will be renewed automatically. If we can't verify them that way, they'll get what's called a request for information. So that there will be additional information they need to send us to make sure that we can accurately verify their eligibility. And then there are people that we aren't able to, because of needing resource information or needing some other pieces of information that we can't verify. We'll send them a renewal packet. So all that is happening in that those first couple of days of April. So we'll automatically renew somebody, we'll send them a request for information, or we'll send them a renewal packet. So then the other thing, and that's what these say, so May passive renewal is the ones that we can automatically renew. The May passive renewals not verified will get the request for information. The May, what we call active renewals, that we need to send the renewal packet to them and they have to take some type of action to provide us information, gets that renewal packet. And then in April, we'll start sending a notice out to people who have a June end date. And so this is the process that will continue each month, where there'll be a lot of things going on depending on when your renewal month is. I want to emphasize again, this is over 12 months. So we're trying to make sure our members understand not everybody's getting renewed in May. In March, our system will be updated with our redistribution plan. So after March 15th, a provider or a member or a connector or somebody who can get into the system and see their new certification date will be on there. So after March 15th, you will be able to see what is somebody's renewal date. So we're also updating our system if, and so a member will be able to go into their Connect account and see when do they renew. We are also looking at updating our call center system to be able, somebody could choose just to find out when their renewal date is, because they're not sure. So they'll be able to call in and press a number and they'll be able to find out when their renewal month is, to hopefully cut down on sort of that confusion about when are they supposed to renew. So I did want to say again, we'll notify the member about 90 days before their when their renewal month is, when their renewal end date is. So if somebody's renewal date is June 30th, they'll get a text again in April, or an email in April. We're also, so let's say it's May 15th and somebody hasn't responded and they have a end date of May 31st. We will also send out a communication to those individuals, making sure they understand that we can't do anything. And you're, potentially going to be discontinued at the end of the month if you don't take action. So we're trying to remind them as well. And we're working on a communication in various modes, such as call and text, and or email, to let them know that they're going to have to take some action and we haven't heard from you. So this is what is just a snapshot. So this is a forecast taken on February 6th of what we believe to be, or what our system right now is identifying may lose eligibility. It's a May. This is just a snapshot. There could be a change in circumstance that lowers this number or raises this number, but what this is our system can go and either tell somebody's no longer, can determine somebody's no longer eligible and probably is going to lose Medicaid coverage, or can't tell whether or not somebody is eligible. And so we're going to have to go through a renewal to find that out. Again, this population will be across the 12 months of unwinding. This is not something that's happening immediately. So this shows us around 240,000 people we can either identify probably has an income over the Medicaid limit, or we can't tell what their situation is. Of those, our system can tell that a little over 76,000 of them are over 138%, so no longer Medicaid eligible. And keep in mind, our system will try to find if you're not eligible for one category, it will automatically see if you might be eligible for another. So we'll be going through all of that prior to sending somebody a notice. So these are folks that we want to understand you could have other coverage somewhere else, like a qualified health plan on the state-based exchange. So these 76,000 individuals, we're going to be really working hard to make sure that they know that and transition them over to QHP, qualified health plan, and the marketplace Connect to see if they want to try to find a plan that's affordable for them. A lot of these folks probably will qualify for advanced premium tax credits, meaning little to no cost for the plan that they could access their coverage. We also have identified some individuals are age 65 and older and qualify for Medicare. And so we want to make sure they understand they have a special enrollment period to enroll in Medicare and connect them with support to help enroll in a Medicare plan. So we're also providing support around those folks. So that's the 65 or older population. We can tell in our system that most of the folks age 65 and older are in Medicare, but there's still some that are not. And we want to make sure we can help them because otherwise they're going to lose eligibility and have no coverage. And they'll be subject to a penalty if they don't do it during the special enrollment period. So these are, these are the folks we're looking at, just trying to make sure that they understand what's happening to them. We want to connect them to other coverage. Some of these folks might have employer sponsored insurance, and we want to make sure they understand that. This is a qualifying life event if you lose your Medicaid coverage. So we're just really focused on this population and making sure they have the supports they need. So I mentioned to you that, we're going to distribute the caseload across the 12-month period. This is looking at some of the special populations that I mentioned earlier. We do have folks, we have about 14,000 individuals that were set to be discontinued when the public health emergency started, but we kept them on, and so they they were already determined no longer eligible, but their circumstances could change. So we're taking a look at them. That's happening in May. We have the Medicare eligible population, as I spoke about. We're going to do them over May through October. And then for individuals that our system can identify that are QHP eligible, that's that qualified health plan on the exchange, we're moving to July through April. And the reason we're doing that is we're doing some other system configuration to assist those folks to make sure that they really can transition over to the marketplace smoothly and with as much help as possible. So what's next? Well, what we really are doing right now is a campaign around having that make sure the Medicaid member has their most current contact information. We really would love a phone number and an email address so that we can contact you about your particular situation if needed. So we're just asking members to keep that information updated. That's really kind of the campaign right now. If you do need help, this is the information that we'll be sharing. We ask that they look for somebody local to help them. They can use a connector or an insurance agent. If they're over 65, they can call that SHIP line or our Department for Aging Independent Living. That's what DAIL is. Sorry about the acronym. And then the other thing is we're keeping all of this information updated on our website. So we're doing it by population in terms of provider, member, and we'll be sharing a lot of information that way. I'm not going to go through these in depth, but again, just a reminder that the flexibilities we implemented around the public health emergency come to an end on May 11th. There are some that we have moved into making permanent. Some will end on that date, and then some we've asked for an extended period of time. So this is just a snapshot. This doesn't include all of them. But we'll be providing more and more information about that as it gets closer so that we can provide notice to everyone about how does that impact you. A lot of these really are going to impact providers, not so much members. I think the biggest thing that affects the member along this is that we've had 2 presumptive eligibility periods in a calendar year, and that unfortunately will go away with the end of the public health emergency. So we'll go back to our original 1 presumptive eligibility period. But we will be sending out notices to providers to make sure they understand what actions they may need to take or what flexibility is ending. And then these are some that we did permanently implement. We expanded telehealth quite a bit under the public health emergency, and we did codify that in our, we did update and amend our regulations so that that we can carry that on beyond the public health emergency. So that's already been done. And then for nursing facilities, we did go ahead and they were getting a $29 add-on. We did go ahead and do a state plan amendment to add that reimbursement permanently to their rate. So I think the biggest thing that we really want to drive home is that communication is key. We're really going to use all forms of communication. Everybody that's on this call today is an important piece to the communication plan. The Medicaid Advisory Council and our Technical Advisory Committee councils are really important in terms of getting the information out. Our provider associations, our advocacy organizations, community-based organizations, and our managed care organizations. Everybody plays a role in supporting our Medicaid members, and we appreciate everyone's interest and help. And so how to stay informed, again, our website, we're going to be posting a lot on our social media. If you're not already a Facebook friend or Twitter or Instagram, I do urge you to in one of those forms of social media, because when something changes or when we add something, we will be putting a lot of information out that way. And then we do have stakeholder meetings scheduled in March. These are the dates and times. We will be sending out more information about this, including a way to sign up. So keep an eye out for that. It should be coming out shortly. But that's kind of what we have so far.
Veronica, we do have a question in the chat.
Thank you.
From Arthur. He says people who are on SSI and Social Security doesn't need a renewal.
So Arthur, we still have to, what we do know is that people who were on SSI or Social Security may no longer be eligible. So you're correct, they don't generally have an annual renewal. They are what we call are categorically eligible. So if you're, if you have SSI, you're categorically eligible. But if for instance, you're no longer SSI, or if your Social Security income increased, then that may affect your eligibility. So we are still required, CMS, the Centers for Medicare and Medicaid Services, are requiring states to redetermine everyone. So all 1.7 million people in Medicaid will go through some type of redetermination during this period of time. And if you've lost eligibility because of that, then yes, you'll unfortunately be discontinued.
Veronica, am I right to think that people who would be in that categorical eligibility wouldn't go through passive renewal? Will they
That-
have to? Is that right?
Yes, that's
Okay.
correct. Yep.
So we need a lot of information out then to certain populations that they will be receiving a renewal packet and will need to complete that packet
That's correct.
and where they can go for help. Okay. Do you have an idea of about how many people would be in that particular eligibility?
Um,
I know I'm putting you on the spot. If you want to get information back
yeah,
to her, not a quiz.
yeah, let me think
Mhm.
about, let me get that
Okay.
number for you.
I had a couple other questions for you. So as far as, oh, where do I have them here? Okay, I found it. You mentioned that some Medicaid enrollees may have employer-sponsored insurance or have access to it. I know some, use Medicaid as secondary, others have access and maybe aren't enrolled in their ESI. Do you have an idea from the information that you already collect from Medicaid members, how many people have access to ESI?
I think to a degree of accuracy.
Yeah.
Yeah.
Okay. All right. And then aside from income, you mentioned that about of the 243,000, about 76,000, you have good data on to know that they're above the income threshold. What are the other reasons for active renewal? The main reasons.
Yeah. So I think unable to verify resources. It really is going to be just unable to be able to do an automatic verification.
And then also those eligibility categories that aren't MAGI.
That's correct.
Yes. All right.
Veronica, I have a quick question. This is Patty. Can you hear me?
Yes, I sure can.
Okay, thanks. You mentioned that for people that needed help, there would be help locally. So that would be like who?
That connectors, we're really trying to encourage people to use the connectors and to the community-based organizations that are connectors, that have connectors. You certainly, the Department of Community-Based Service local offices, they're going to be available. But we're really trying to drive people that have to go through that active renewal and have to present documentation. Those are the ones we really want to be working with DCBS. But and then the other thing that I just, since we're talking about it, the managed care organizations are going to be outreaching to their members directly too, and helping them connect with people that, for instance, if you do need to upload information, and the managed care organization calls their member and the member says, yes, I need some help, they also can connect them to somebody who can assist that member with uploading information or getting us the information we need to make that determination. Does that help, Patty?
It does. It does.
Okay,
Thank you
great.
very much. Yeah.
Yeah.
I figured DCBS, but managed care associations too would be real helpful. Okay. All righty. Thank you.
You're welcome.
All right. Any other questions? Thank you for that overview. I think that's
You're
really
welcome.
helpful.
And I think the rest of the DMS staff are prepared to walk through the rest of the information. But if there's anything else, don't hesitate to reach out. And thanks, everyone.
Thank you. Okay, so we'll jump back up to the first couple of items that are questions, just sort of our standing data requests. How many Kentuckians are currently covered under traditional, expanded, emergency Medicaid and presumptive eligibility?
So good afternoon. My name is Justin Derringer. I'm with the Kentucky Department for Medicaid Services. We have a total member count, the last member count of 1,720,719 total members. Of those, 1,559,474 are in managed care. As far as expansion, there's 653,445 in the expansion group. 1,067,273 in the non-expansion group. And then we have right below 4,000, so 3,900 approximately members in time limited Medicaid at this time.
Okay, and presumptive eligibility?
I actually don't have the presumptive eligibility numbers. I'm not sure where those went, but I don't have those handy right now. I've got them in an email somewhere and I kind of misplaced it. So I'm not sure exactly where those numbers are, but we can get those sent over to you.
That would be great.
Emily, this is Erin. If you give me just a second, I have that report I can pull up.
Okay, great.
There you go.
Thank you, Justin.
Absolutely. And we'll get these, we'll get these over to you. So you can send them out to everybody so you have them.
And while we're waiting on Aaron to pull that up, do you also have the number for the people covered under the 1915C waivers?
No, I do not.
Hey,
Aaron, do you?
Emily, it's Pam. I have it.
There
I
you go.
have it, Emily.
All right.
You want me to go in? I can go in and give it to you now. Hold on. I was doing some updating it really quick. So total we have right now on all 6 of the waivers, we are serving just over 32,000, where it's about 32,689 individuals total. We have wait lists still only in 2 of the waivers. So we have wait list in Michelle P and SCL. There are, and these numbers are, these are of about 2 weeks ago, so I can get you all current numbers out, and I'll send this so that you can send out to the group. But there's 8,021 on the Michelle P wait list and 3,059 on SCL, with none of those being on emergency for SCL.
Okay.
Emily, this is Erin again. Our PE numbers as of Monday, the 20th is 1,488 members.
All right, thanks. So
292 of those being new members.
okay, that's been relatively steady. Any questions about that?
Did you say no emergencies, Pam?
Correct. There are no individuals on the emergency wait list for SCL.
Okay. Okay, thanks.
All right. Well, thank you all for that information. We'll hop back down to I think is the next item, the rate study, the home and community-based services rate study.
So where we are at this point is the rate study findings have been shared with executive staff, and they, as well as all of the budget impact analysis and the other analysis that we had to do for that study, it is with executive staff. Once they have reviewed, then we will be sending everything out for public comment. And so we'll send out notifications when that happens and make sure everybody knows when all that is posted and that it is available for public comment. But hopefully that is going to be in the next, hopefully the next 30 days or so. Of course, I can't, that's according to my wishes, and I can't, it's up to those that are higher than me reviewing it to decide that. But fairly soon, hopefully we're going to be able to share that information.
Right. That's great. Thank you.
Mm-hmm.
I know a lot of people are looking forward to.
I know everybody's, and I wish that I could. I wish I could share now, and I can't. I can't share that information yet. But I'm excited for us to be able to share that. A lot of work went into that survey and that study.
Arthur or Patty, do you have any questions about that?
Actually, I don't think so. Look forward to seeing the results of the study though. So yeah.
Great.
Right. Am I ready? You will
Right.
wait.
Yeah.
Tell them.
Hmm.
Okay. Is the
Yeah.
Arthur say he will wait.
Okay, and Arthur, I'll make sure that you get notification that they're ready to be reviewed.
Thank you.
You're very welcome.
So Pam, you've been giving us updates on the PACE program rollout. Has there been any more progress there?
So we still have our two enrolled, the two PACE organizations that were the first to enroll, which is Bluegrass Care Navigators and Horizon PACE. They cover, between them, Bluegrass covers 5 counties, Horizon covers 11. Our Jefferson County organization, we believe will be ready to start enrolling individuals by May or June. They're in the final processes of their contract finalization and enrollment, where Medicaid, CMS, or not Medicaid, that would be us, where CMS has to sign off. But we have, their 3-way agreement has been signed and sent to CMS, and so they're just in that last little bit before they can officially begin enrolling people. But we believe that by May or June, they'll be able to start enrolling individuals. To date, since August 1st, we have enrolled 66 individuals into the PACE program. So we're very excited about that, very excited to roll it out in Jefferson County as well. Currently, we are working with with the waiver providers, working on some education materials to help them understand how they can be a referral source into PACE, when to recognize an individual may be served better through PACE, as well as doing kind of that flip-flop education with the PACE providers, and when is PACE not necessarily working for an individual, but yet just the traditional home and community-based program, or, you know, as we know it today, the waiver programs, if they would work better for an individual. So really starting to look at that education, getting some information out to them. Also looking at how we can transition from, you know, our individuals that we transition out of nursing facilities using the Money Follows the Person program, how to make that be a referral source into PACE, either after they've transitioned, or as we are getting inquiries from the nursing facilities, sharing with the PACE organizations if there is somebody that potentially could come straight out into PACE and maybe they don't even need to transition out with MFP. So really working that as a referral source as well.
Yeah, having that educational material would be really helpful.
Yeah, we're
Share with the
I
public.
just saw a couple of things going back and forth this morning on it. They were doing I think some final tweaks on it before we're getting ready, and we'll be ready to share it. And of course, we'll post it to the website, but we can also share that, Emily, with you all and with this group as well, so that you all can share it, because, you know, I'm all about however we can get that information out there. That, you know, the more ways, the better. So
Definitely. All right, thank you, Pam.
you're welcome.
Anything else that you were planning on covering?
I do not believe so. I do have to step away about 3. So if anything comes up after that, for me, if you all have my information, you can shoot me an email, or if you let Aaron or Kelly know, they can get with me. But I'll be on until about 3 o'clock.
Great, thanks.
All right, thank you.
The next item we have here is the Kentucky Medicaid Quality Strategy Plan. Just want a kind of status update on that.
Well, we still haven't heard back from CMS. This is Angie Parker from Medicaid. But it's more or less a submit and use. So that's what we're doing. That is still our guidebook on quality for the next 3 years, or at least, I mean, we will be evaluating it quarterly or annually to see if there are any changes, or with what we have put in the strategy, how those measures are working, if they're improving.
When do you expect to have measures or data on those measures that you can share?
Well, they are HEDIS measures for the most part. There are a few that are not. So now is HEDIS season. So we won't have the HEDIS results until August, I believe, August, September.
Okay. So we can maybe get that report at
Mhm.
are we August? I think it's October would be the month after that, but I shouldn't rely on my memory since we meet bi-monthly. But we'll
I'm
plan to put
sorry.
that on the agenda in the fall. Is it October?
I was just asking what are the measures you're talking about? HEDIS? What is that?
HEDIS measures. You would ask me what HEDIS stands for. Healthcare Effective Data Information Sets is basically what it is. Now, there are about 55 HEDIS measures that all MCOs have to report on. Not all of those measures are in the quality strategy. But for example, what is the number for their patients who have a hemoglobin A1C of 8 or greater or less than 8? There are different diagnosis, preventive measures, specific measures to like breast cancer screening. For whatever reason, I'm having a loss of memory at the moment, but I can certainly supply what all those measures are to you.
I was going to say, those are some good examples. You know, it's the screenings, utilization, looking at, chronic disease management. But if you could share with us the specific measures that you're tracking, that would be fantastic.
Well, I mean, they're all like I said, the MCOs have to report on all of the HEDIS measures. All of the HEDIS measures that we are including in the quality strategy are in the quality strategy.
Okay. And then I think related, and maybe as part of your quality strategy, is the hospital rate improvement program. And we had talked at either the last meeting or the meeting before about getting a report on, what those quality metrics are for the hospitals and what the results are so far.
Well, we don't have 2022 yet. That we probably won't have all those quality results until the end of May. They are working on hospital readmissions, sepsis screening, catheter association urinary tract infections ratio, Clostridium difficile standard infection ratio, safe use of opioids for concurrent e-prescribing, and social determinants of health. That's at a very high level.
Okay, so by the end of May, you'll have something that you could report more specifically. Okay.
Yes.
Great, thank you. And actually, one follow-up question. I know there's a bill that's working its way through the legislature now to expand that hospital rate improvement program from inpatient services to outpatient services. I'm assuming there'll be different quality measures tied to those.
Yes.
And do you have those measures?
Not yet.
Are they not developed yet, or?
Correct.
Okay. All right, thank you. And just as a reminder, and especially for Brenda, this is a program that increases hospital reimbursement rates tied to their performance on quality measures. So I think from year to year, if hospitals are actually, achieving these quality measures, then they would be paid the average commercial rate rather than the Medicaid fee schedule, which is a big difference. It totals well over $1 billion a year. All right, the next item we have here is Medicaid reimbursement for licensed certified professional midwives.
Hi, this is Dr. Terrio. At this time, we do not have next steps or any plans on working on that at this time.
Okay, yeah. Thank you.
Thanks.
And then our next item here is the implementation plan for the certified CHW reimbursement.
That would be July 1st, 2023.
Has it been approved, Pam? I'm sorry.
Not yet. We haven't gotten that approval yet from CMS, But yes, we're looking at July 1st, 2023.
Okay,
And the 3 codes that can be billed can also be billed outside of the clinic walls. It is, these 3 codes are on the physician's fee schedule. And they are 98960, 98661, and 98962.
all right. Well, it's great news that those can also be billed outside clinic walls. So thank you for your work on that. I know that was a big concern of many of the CHWs who are working in their communities and for community-based organizations rather than for clinics. So really appreciate that. Any other updates about that plan?
You know, your next question was, what options will community-based organizations have for contracting with Medicaid provider in order to participate? That will be between you and the Medicaid provider. Obviously, we enroll providers, so they would have to be a Medicaid enrolled provider in order for those codes to be paid.
So it could be a contract though with a Medicaid enrolled provider.
Yes, you would have to contract with a Medicaid enrolled provider, and that enrolled provider would have to do the billing.
Right. Okay. Is there any guidance that can be provided to CHWs on how to establish that kind of relationship?
I don't at this moment.
Or maybe particular groups that are doing something similar. I'm thinking about maybe peer support specialists where a CHW could talk with another group doing something like this with contracting to get an idea of how to do it themselves.
You know, I can't answer. That's something I can certainly look at. Also, you know, our health equity branch that, or I guess the community health worker branch in public health may have some thoughts as well.
Good point. Okay. All right. Thank you.
Mhm.
Any questions before we move on? So we've got network adequacy up as our next item. And one of the questions that we had as we've been, thinking through this process more is what data MCOs are reporting to DMS on network adequacy.
There are a few. There's a report that is an exceptions report that is reported quarterly. That if they aren't able to meet network adequacy due to, I can't read my own writing, there being a provider shortage or a shortage in particular specialty or issues in the location. So that is reported to DMS on a quarterly basis. They also report on a geo mapping and access report by time and distance on a quarterly basis. And also a timely access report, which they're to do quarterly audits on whether or not providers are available within the contracted rate for emergency or normal time period for a routine office visit.
Okay. With the exceptions report,
Mhm.
if an MCO is reporting, and of course that's understandable that there may be a provider shortage or there may be in a particular area of the state, not enough providers of a particular specialty, but would that exempt them from having to meet the requirement for network adequacy, or would that mean that they would then have to provide an out-of-network provider?
They would have to be able to adjust if it's necessary for their members to see a particular provider if they do not have it. So I don't know, say there's a shortage in surgeons in a certain county, which, a lot of people do have to travel from, because of being a rural state, do have to travel for surgery. But that's 50 miles, 50 minutes.
Right.
And so if they didn't have someone between a surgeon and 50 miles, 50 minutes, they would have to work with the member to find someone that they could see.
So if they.
Whether, yeah, it could be
So in
out of
that case, it
network,
could be
but
an
if,
out-of-network provider.
I mean, if they have a surgeon within their network and that provider, they can work to get that provider. So the surgeons say it's 60 minutes and 60 miles. They would say, well, we have this provider who is in 60 minutes or 60 miles. And that they would recommend they go to that provider.
But if there is a surgeon not in their network, but available and closer, they wouldn't be required to.
If they don't have a provider in their network, then they have to work with a member to and identify a potential provider for them and possibly do an agreement with that provider.
Okay. So we're out of network care.
Mhm.
All right. So another question that we had is, you mentioned audits that happen quarterly, and I know I've seen secret shopper survey data. When there's a finding that, the network adequacy isn't being met or it's inadequate, what corrective action is taken?
Well, with those reports that our external quality review organization does for us, and of course the MCOs are to do that as well. That report is shared to the individual MCO, and they are to address any areas in which it's been identified, particular provider, and the MCO is to work with that provider.
There's no specific corrective action then other than just.
Well, there could be, I can't say it's a blanket thing. It could be a letter of concern, or, it depends on what the MCO comes back and says, we followed up with this doctor and this is what we've done. So I guess there is a corrective action. It's just not a formal corrective action. The expectation is for them to take this report and to find out what the issues were in that study.
And then, we kind of touched on this already, but if network adequacy isn't met, if the individual is denied an out-of-network provider, so in the case that, the MCO doesn't provide the out-of-network provider, is there a process for reporting that information to DMS? How does DMS know when, the out-of-network provider is or isn't approved?
We wouldn't know unless the member contacted us or complained. They can also appeal that to the MCO as well.
But the appeal doesn't go to DMS, it only goes to.
Correct.
Seems like it should go to DMS in that case, but. All right, that's good information to have. And then, what can an individual do to get out of network care if they can't or don't want to change their MCO for other reasons? Based on the one pager which you put together, and it was helpful to see, but it occurred to us that, there may be reasons that somebody doesn't want to just switch to a different MCO. Could be that they have another provider that they go to that the MCO, covers, and they really want to keep their coverage for that reason, or it could be value-added benefits that, they really want to keep that particular MCO, or maybe the rest of their family is covered by that MCO. I could imagine a number of scenarios where, that wouldn't necessarily be their sort of preference to have to switch. So is there a way to get out of network care?
And only if it's an emergency.
Only if it's an emergency.
And that there's not another provider in their network that can provide the service.
But within the standards.
Correct.
In the time and distance standards. See, I feel like at least what we hear, when we hear from people who say there's not a provider in their area within those time and distance standards, we very rarely hear that they're offered out of network care. They are often told to go somewhere further away, or they're waiting longer amounts of time. And I just don't feel like this is kind of adding up to, network adequacy being met.
And I can say that it's probably not. I mean, when you hear those stories, it's always very helpful for us to know what the specific circumstances are, so that if we need to, we can address it with the MCO.
Is there a particular way to report those problems?
There is that, and I believe I've shared it at one point, but I can get that to you. There is through our contract compliance branch, on our website that has a complaint form.
I can send that out in a follow-up email after the meeting.
Okay,
I think that would be really helpful. Thank you.
I had a question.
Yeah, Miranda.
Oh, let me use this. So for the reports that you mentioned that the MCOs have to submit, so the number of members that appeal to their MCO for network adequacy or anything else, I guess, does DMS not receive a report on number of member appeals to MCO?
We do get an appeals and grievances report from the MCOs. We also get a disenrollment for cause MCOs that tells us why they're wanting to disenroll and or if they did allow to disenroll, and if they didn't, what happened. And looks like Victoria Jude from Anthem has her hand up.
Yes, I just wanted to add to, we have a plan utilization management team that approves those out of network requests to as needed to address the network adequacy gaps.
Thanks, Victoria. Can you explain a little bit of how that works?
I can write up a follow-up email if that would work.
Yeah, that would be great. Yeah, I'm curious to know if MCOs have a similar process or if each one does it a little differently.
Good afternoon, Emily. This is Chris Kern with United Healthcare. I would also add into Anthem's response that we do have a process where a member may need out-of-network care. Our case management team does a gap search of providers. If there's a network provider available, then we will give the member a list of available network providers. If there's not, I believe Angie spoke to doing an authorization for out of network and a single case agreement so that the provider can get paid. So, we have a very robust process to try to make sure that our members have access to care. As Angie mentioned, there are areas of the state maybe where there just isn't an unavailable provider, but we will work with the member to make sure that any barriers to obtaining care can be addressed. And if transportation is an issue, we'll certainly work to make sure that that's furnished for the member as well, so they get that needed care.
This is Samantha Harrison with Humana Healthy Horizons. All the same, repeated. I don't want to continue to tag on other than to say there are situations where providers aren't currently enrolled in Medicaid, where all of us as MCOs, while we attempt to do single case agreements, if that provider is not willing to become enrolled in Kentucky Medicaid, we can't pay the claim. So as much as a member may want to see a particular provider, if they're not willing to get enrolled, it makes it a very difficult scenario. And it often looks like we're not doing our part. But we as MCOs are working with our members to ensure access and adequacy. Also, in our reports on the aspect, we do include any denials or approvals for out-of-network providers as well on the utilization management reports. So that assists DMS with that information. Just wanted to add that side note. Thanks.
No, that is helpful to have. All of this information is really helpful. I think it's just a process that people don't understand very well and don't always know how to get the right kind of help.
Right, and the MCOs help these providers with that enrollment as well with DMS, Emily, just to let you know. We can guide them to DMS enrollment, but we also can assist them in getting enrolled, so.
Okay, that's good to know. And since we're already talking about this, I had it under a sort of general discussion because that's the way we lay out our agenda, but we did have a couple of questions for our MCO partners and wanted to know first, if MCOs could tell us how many out-of-network providers were approved by their particular MCO in 2022. So I guess that would be the single case agreements. And then what provider types are those generally?
I can speak to that for Humana. This is Samantha again, Samantha Harrison. We had 21 in the calendar year of 2022 with various provider specialties such as DME, emergency medical transportation. Those are right off the top of my head for what we had, but I can give you more details behind the different provider types in an email. That works.
That sounds good. Thanks.
If any of you want to share those details with the TAC group, you can email me those and I will get them out to the group. Hopefully kind of cut down on the number of emails everybody gets.
Thank you. That sounds great. We'll do that.
Emily, this is Chris Kern again with United Healthcare. We have requested a report to be able to provide information on that. And we'll make sure we get that to you as quickly as possible. Also want to make sure, kind of following up to one of the other items I'd mentioned, our member services team stands ready to help members if they're having trouble locating a provider. And we also have our provider directory out on our member website, and we'll share that information in the follow-up email as well.
Thank you.
Hey, Emily, this is Kelly with Aetna Better Health of Kentucky. We also have noted this request for data, and we have requested a report from our PR team, and we'll be sure to zip up those trends for you on SCAs and then by provider type, and we'll submit that all through Pam at Medicaid.
All right, thank you.
Hi, Emily, it's Anna Page with Passport. We'll do the same as well. We'll email you those results.
Okay.
Emily, this is Stuart Owen with WellCare likewise. And I will note that I forget who it was. I was talking about the specialists. There are some in Kentucky. There just simply are not many specialists, and one of them is pediatric psychiatrist. That's definitely one that we have trouble with. Eating disorder providers as well, and also pediatric urologists. But I mean, I'll send you information. But those are specialists in particular where there's just hardly any in Kentucky.
Well, and we recognize that the information that is the information from licensure boards is not always very accurate, and really could use some additional information from providers about where they're practicing, how often, how much they're practicing, if they're accepting Medicaid, that sort of thing, so that it can, basically be translated into more accurate provider directories. That's something that I know is not only a Medicaid issue, but for all insurers. But thank you all for that information. Victoria, did you?
I'm sorry, this is Paula, also with WellCare, and that is definitely one of the goals we have, is to try to survey our providers to see what they treat and what they feel like they would like to treat, so that our customer service team and our care management team can refer to providers that match the members' needs. So that's definitely a goal in the next year to 2 years, to make sure we have accurate information on providers. One other provider group or one other area that we need providers is residential treatment for kids. We have to send people out of state, and that's just not a good thing to do.
Yeah, we hear that often. Well, if you do the survey, sharing those results would be great. I think it'd be really informative and certainly something.
Sure. It's a process, but we definitely will share once we get some feedback.
Okay, and the same for any other MCO. If you're asking questions of providers and getting information about, how many patients they're accepting, where they're practicing, that sort of thing, that would be really helpful. Arthur, I just saw your question in the chat. I do have a few recommendations that I wanted to propose, and we could go ahead and do those recommendations before we go back to the new business items, if that would work for everyone.
Emily, I apologize. We're gonna have to go back and approve the minutes. And I'm gonna have to ask all members to please turn their camera on for the vote.
Oh, I thought at the time everyone's camera was on, even though some cameras are off now.
I don't think Patty's was on.
Oh, okay.
I'm not trying to call you out.
Patty, would you be able to turn your camera on?
I'm good. Did you hear me, Emily?
I heard you, but I don't see your video yet. And then I can't see everyone else. So I'm not sure if everyone else has their camera on at the moment. I see Miranda, I see Brenda. Oh yeah, Arthur. Okay. Can you turn your camera on for just a minute, Patty?
I do apologize, but in order to comply with the open meeting laws, whenever there's a vote, the members who are voting have to have their cameras on.
And Emily, this is Erin. I just want to butt in really quick. Did Brenda take someone's place on the committee?
Yes,
We've not received
that was
notification
in
on
an
that.
email. Brenda is representing AARP Kentucky.
Okay,
Christy-
can you make
Christy
sure that the
Jackson.
state gets a copy of that email? Because we don't have any notification of that.
Okay. I
Thank
thought
you.
we did, but I'll go back and look.
And welcome, Brenda.
Thank you.
Yes, and we announced that at the beginning of the meeting. So Patty, if you're not able to turn on your video, and I'm counting that we have 4 voting members who do have videos on out of 7 total members, we still have a quorum.
There we go.
Oh, perfect.
There we are. Got it? Yeah.
All right. So now that we have videos on, I'll ask again for a motion to approve the December minutes.
I make a motion to approve the December minutes.
Thank you, Miranda. Okay. Thank you, Arthur. All in favor, say aye.
Aye.
Aye. Any opposed? Okay, the motion carries. And actually, Patty, if you could keep your camera on for the recommendations. I'm sorry, I forgot that we need to vote on those as well.
Okay.
So one of the recommendations that I had in mind was related to something we haven't discussed yet, but that's value-added benefits. And, in looking at the value-added benefits side by side, it's grown quite a bit. And it's great to see. It's great to see how many value-added benefits each MCO is providing and kind of the breadth of benefits. But it would be nice to know a little bit more about how somebody can access those benefits and just any, kind of details about who would be eligible, because some of them, I think are for particular populations. So one of the recommendations I wanted to make is that DMS collect additional information on value-added benefits to put into some sort of supplementary sort of guide for people to either understand if they're eligible or how to access those benefits. And I think that would be a really useful tool for connectors and community health workers and others who may be assisting Medicaid members. So that would be one recommendation. Any questions about that? Like I said, I know we haven't really had a discussion about it yet. And Miranda, you'd probably be the person who maybe uses that side by side the most, I would assume. Does that seem like something that would be useful?
Yes, and my experience with the value-added benefits side by side has been like, it's useful information, but the information for one MCO is in a different order than the information for another MCO. And so it can be really difficult for consumers and connectors to compare, like, okay, I have to scan and find where does it talk about expungement help for Anthem versus Passport or whatever. Like they're not in the same order. So it would be easier to compare if they were in the same order.
That's a good point too. Yeah. So both on the side by side and then in a supplement. I know because it's a lot of information on a relatively small sheet of paper, and some MCOs, that they don't all provide the same benefit. So it might be hard to sometimes kind of track those across, but as much as possible, I think that would be helpful. And then having all of that information in a comparable format in a supplementary guide, I think would be really useful.
Emily, if I may on that, and I don't, the MCOs may have that in their member handbooks, and I know that doesn't help you all. But I would have to defer to the MCOs on the call on how, because the side-by-side wasn't really meant to be a high level, what value added benefits that they have available, so that they would, reach out to the MCOs on something or participate, or whether or not they get there are certain, I do know that there are certain programs they have to participate in before they can get something, but I will defer to some of the MCOs on some of that before you vote. And looks like Victoria Jude from Anthem has got her hand raised.
Yeah, Victoria. It may be there.
I was gonna say, this is.
Sorry, I didn't realize I was muted. I was talking away.
Well, Victoria and then Owen.
Okay.
I'm sorry.
Yes, she's correct. We do have it listed in our member handbook, and also we provide learning sessions for our community partners and our members, a new member orientation once a month to go over VAB details and eligibility. It's also the details are the members can actually access that in their member portal. In their account, we have that laid out for them to know what they're eligible for and how to redeem the benefits. We don't currently provide this information to DMS, but we do have it available.
Yeah, that's good to know. And Stuart, did you have something to add?
Yeah, I was gonna say, it's probably similar for all of us. I mean, basically you can call customer services, you can go online. Most of the value-added benefits, you just ask for it. There are a handful, at least for us, that you got to do something, preventive visits or whatever to get it, like gym membership or something like that. Most of them you just ask for it, and it's either calling customer service or going online. But we have as well, we do a quarterly newsletter that we send out to members that talks about this. It's in the handbook, has been mentioned. Our care managers talk to members about it. We have events with our community partners, and we give them information to share with members as well for community events. But basically the most common way is either just calling our customer services number or going online.
Okay. I think in both those cases, if you have already enrolled with that particular MCO, it makes a lot of sense that you would be using the member handbook. I think I'm thinking of it more as a kind of a way to educate people who are trying to decide which MCO, and that side by side is very popular during open enrollment. So I was just thinking that if we could kind of point someone to additional information and it be all in one place, that could be really helpful.
If there's a phone number, like maybe if the phone number for each MCO customer service was added to it, and maybe even member website or something, on the top, that might help.
Well, I mean, it is mailed out with the information regarding open enrollment. And it's, I mean, but it doesn't have which does have your phone number in it, in that letter.
Okay.
It's not on the side by side, but it is in the communications.
We're in the process also of getting those Anthem 101 and member orientation sessions added to our website. I think that might help as well.
Yeah, any additional information that could be linked, or if it's a direct number, where people can know that they're going to get their question answered. I
Hey,
think-
Emily, it's Michelle Hughlin with Passport. Basically echoing the same as the other MCOs. And we do have, as far as on the website, daily member information sessions that they can attend, and they can go into detail on as far as how to access, walk them through benefits, and, echoing what the other MCOs say. So those were also held virtually all during COVID, and we're continuing those virtually as well as some in person.
Good to know. Thank you. Dr. Terrio, did you have something that you wanted to add?
I was just gonna say it's from a provider point of view, you don't really look to see what MCO your patient has. But if the MCOs want the providers to be kind of a partner and say, hey, you're with Anthem, do you know they have this great diabetes program, and kind of help get people into some of these great programs. A side by side would really help, to not necessarily, go out to the public, but to go to the providers so they can really help engage the patients in some of these value-added programs.
Okay. Yeah, thank you. That's good feedback to have. I see Ashley and Jeff, you both have your hands up.
Yeah, Emily, again, kind of mirroring what the other MCOs have said, we have our information for accessing our benefits in our handbook, and all that information's on our website. A lot of that directs our members to either view the handbook or contact enrollee services. I'm sorry, I forgot to mention I'm with Humana. In addition to that, we do educational flyers on our value-added benefits and our healthy rewards programs. Those are presented to members and at outreach events, and we discuss those topics in our quarterly member access committees, which basically are the enrollee feedback sessions. We also have some outreach campaigns that we do about specific benefits. For example, we did one on colorectal screenings and our value-added benefits around additional screening options there. And when folks complete our health risk assessments, that also kind of queues up some additional benefits that folks would be eligible for, as well as enrollment in our care management program will also prompt us to explore with those what benefits they're eligible for or what they could benefit from.
Thank you.
Yeah, you're welcome.
Hi, Emily. I'm echo what the previous MCO said, and I'm also wondering if it would be beneficial. It sounds like we all have some type of member education, whether it's daily, weekly, or monthly. Would that be of benefit if we collected that information and provided it to the TAC?
I think so. Yeah, I think what can be difficult is when there are 6 MCOs and they have 6 handbooks, and it's just really hard to keep up. And to see all that information in one place, I think is helpful when you're trying to educate the community. And, you're talking to people with different coverage, and you want to be able to give them sort of one resource. So that's really what I had in mind in this case, to better help kind of promote these things and get people using them. But maybe for this particular meeting, it's a little premature to make this recommendation. So if people want to share, if the MCOs want to share some additional resources, we can take a look at that and just revisit this for the next meeting. And I know that Arthur, you need to get going. So I'm going to share the other 2 recommendations that I had in mind. And of course, if anyone else has recommendations that you want to put forward, this will be the time to do it. So again, related to network adequacy, I think I'd like to recommend that DMS provide an avenue for members to report directly to DMS any network adequacy violations or issues, so that there is that extra, level of appeal. So that would be one recommendation. And the next would be that DMS require MCOs to disclose any religious or moral objections upfront, when someone is enrolling, selecting an MCO. I think it's better for that information to be provided at that time than in the member handbook, for instance. Can I get, is there any discussion related to those recommendations?
I was just gonna ask, regarding the disclosure of religious or moral objections at enrollment. I'm trying to picture what that could look like. I mean, would that be, and maybe we don't need to know this. I'm just trying to imagine, because when I'm in Connect, there's just like one line of like, this is the name of the MCO to choose. And when, during open enrollment, there's the list of value added benefits. So that's what, unless people do go to the MCO website, that's all the information they might be seeing.
Yeah, I think if they're on enrollment materials or just as a banner, if there was information that you could click for more information, it wouldn't necessarily have to be presented right there on that screen. And my understanding is that right now there aren't moral or religious objections for particular services. But again, if that is the case, no one would know that when they enroll. And I think that that's an issue. So this could be another one that we want to discuss more. I'm okay with waiting on these. Are there any other recommendations that people do want to put forward? Okay. Well, Arthur, I think that we're good as far as voting. We shouldn't need to take another vote before the end of the meeting. So I appreciate your time. And if you need to hop off, we totally understand.
You're going?
Bye.
Bye. He said he's leaving, he's logging out, so bye.
All right, thanks, Arthur. And so I think now that we have, actually, under new business, we were talking about value added benefits and we had hopped down to recommendations. And we've already obviously discussed this to some degree, but there was one specific question that we had about the side-by-side. When behavioral health services were added, it looked like some of the services were covered services. And this could just be an issue of it being summarized to the degree to fit on, that small side-by-side. But my concern is that if somebody were to look at that side-by-side and see something that looked like it was a covered service, that they would, and it was, let's say, just as an example, listed by Anthem as a value-added benefit, somebody may not realize that that's a covered service that they would get under any MCO. There were just
Well, this hasn't. This was a request from the behavioral health TAC
the side-by-side.
to include specific behavioral health SUD type services. It's not exact. You're correct. It's not a value added service for the most part.
Okay,
but it
So
was
when-
added to. It was added to because all behavioral health and SUD they're eligible for all the value added services. So they had asked for specific areas like eating disorder, and I can't remember exactly what that, but they had asked for specific behavioral health SUD services that they cover. It's not necessarily a value add, but it was included on that so that they could see that even though they're behavioral health SUD, they also have these other services that are available to them.
I see.
Yeah, this is Paula too with WellCare, and I think the primary care TAC also asked for that information just because they just wanted to know what was available to the members.
I mean,
It
I
is
think it's-
confusing.
I
Yeah.
think it's good information. I think it's confusing because it's added to value-added benefits, and that's very different, right? Because when you look at the value-added benefits, of course, not every MCO is offering the same thing. And I just don't want to give people the impression that if it's not on that list, an MCO isn't covering a service, it's a covered service. It just seemed like there's some, maybe for more consistency, we need to make sure that if it's a covered service versus a value added service, that's really clearly defined. And I think better for MCOs because, you want to make sure that people aren't assuming that just because it's not on that list that you're not covering that particular service. So that was something that I think can cause some confusion. And if there could be any sort of just going back to it and making sure that it's consistent across MCOs and that we really highlight value add versus covered service, I think that would be really helpful. And then again, that supplementary guide that I mentioned before, I think having all of the information that is probably in your handbooks, but in one place so that providers, community health workers, connectors can actually assist people in seeing, what the eligibility criteria is and just instructions on how they would go about getting a particular value-added service, I think could be really beneficial. But we don't need to make that as a recommendation right now, just something to consider. Going to member handbooks, though, it can just be really, it's something some people will do, but for the most part, if you're talking about, working with people in the community who have different MCOs, it becomes kind of difficult to always keep up with what each MCO is doing. So just some ideas for how we can better promote what these value-added services are and make sure people know how to use them. And then is there anything else that people wanted to raise related to the value-added benefits? Any questions, any thoughts? The list has been growing, it seems like year by year, and it's great to see that there are so many. And maybe at a future meeting, we can get more information about how many people are participating in those benefits. I think that would be really interesting to know. And if there's anything that we can do to help kind of spread the word. I'll ask again for recommendations, just hopping back down to that item on the agenda. If we have none, then we can just make sure that we have all the details for our next meeting. I will be representing the TAC at our upcoming MAC meeting. As far as next meetings, our meeting schedule is listed here. We did talk about rescheduling the December meeting to December 5th. And Erin or Kelly, I don't remember if that's something that we needed to confirm with you.
Yes, that would be good. I know we'd sent an email out with different dates. Unless I just missed it, I don't see that we ever confirmed the 5th. So I'll go ahead and get that updated on the website and update the calendar invite.
Okay, that would be great. Thank you. And then we also have our MAC meeting dates here, and the next meeting is, oh, I didn't update that. I'm so sorry. Actually, could you tell us what the next meeting is? It's March, I know that much.
March 23rd.
March 23rd, thank you. Sorry for overlooking that. All right. I do think we take a motion to adjourn. So if I could get a motion.
Hey, this is Miranda. I motion to adjourn.
Thank you. Second. Patty or Brenda?
I'll second it.
Thank you, Brenda. All in favor, say aye. And Patty, you might need to turn your camera on,
Aye.
although for adjournment, it may not matter. All in favor, say aye.
Aye. Aye.
Any opposed? Motion carries. Thank you all and appreciate your participation today, and we'll see you in a couple of months. Thanks so much.
Thank you.